Good morning. Oh, good. Some of you are still awake. That is terrific. I hate being the third speaker because for an hour you can really hold on tight, but that extra half hour, you're starting to slip away. I'm going to ask you to stick with me. I promise I'm going to try to make this worth it. So I wanted to start with a fundamental concept to the management of patients with vasculitis. We'll see how that goes, and we'll just go from there. So this is the concept I'm trying to get across today. If Travis Kelce and Taylor Swift were both diagnosed with vasculitis today, there's no way these patients should get the same dose of drugs, right? Because just volume-wise, Travis Kelce has got to be at least 2 Taylor Swifts. So this concept really applies more to vasculitis than it does to even most rheumatic diseases. Because if you think about it, each vasculitis diagnosis really represents a spectrum. So you could have 2 patients in the same room, both diagnosed with EGPA. One could be dying with myocarditis and pulmonary renal syndrome, and the other one could just have a bad wheeze. And yet they still get the same label. So with vasculitis in general, it's really important to think about the individual patient and their individual manifestations to figure out what you need to do for them next to get them better. So I would love nothing better than to spend the next 9 hours talking about each form of systemic vasculitis and talking about the nuances of how you manage each disease. But then Jack would shoot me. So instead of doing that, what I've decided to do is I picked 2 diagnoses to focus on. So the first diagnosis is giant cell arteritis, and the second diagnosis is eosinophilic granulomatosis with polyangiitis. But of course, I'm happy to take questions about other forms of vasculitis during the question and answer session. So first, we're going to start with giant cell arteritis, and we're going to go through a case. So this is the story of a 70-year-old man who presents with 2 months of weakness, fatigue, and malaise. Last month, he was evaluated by his primary care provider who diagnosed him with a viral syndrome and sent him home with a recipe for chicken soup. Chicken soup was great, but unfortunately, 1 week ago, he developed a left-sided headache. On review of symptoms, he had a low-grade fever and he had some weight loss, and not surprising to anyone in this audience, he had an ESR of 102. So, what's the next best step in this patient's management? Urgent temporal artery biopsy, administer 81 milligrams of aspirin immediately, referral to an emergency department for pulse steroid therapy, or starting him on prednisone 40 milligrams a day and tocilizumab. Okay. Seems like the only one that you guys don't like is aspirin, but then there's a little bit of a mix. So I was thinking to myself, how do I explain my thought process when it comes to the treatment of patients who have got giant cell arteritis? Because a lot of thoughts go through my head. And it was getting really complicated, and then suddenly I remembered something important. The Sound of Music is my favorite movie. Have all of you seen The Sound of Music at least once? So there's this iconic part of The Sound of Music where Maria von Trapp is trying to explain to the kids how the scale works. And at some point, just like any good teacher, she realizes she's completely lost her audience. They have no idea what she's talking about. But then she pauses for a moment and realizes that actually fundamentally it's not that hard. So this is my doe a deer moment for treatment of giant cell arteritis. I will not be singing for you today, so you don't have to worry. But I realize when you're thinking about the initial therapy of giant cell arteritis, there are only 2 questions you have to ask yourself. Question number 1 is, has this patient had this before? Is this a new diagnosis of giant cell arteritis or recurrent disease? The second question you got to ask yourself is whether or not that patient has visual symptoms. And because this is a key clinical question, I think we have to go into a little bit of details in terms of the symptoms that you care about and the symptoms you don't care about. So the symptoms that are less concerning are the symptoms that we all have at the end of a long clinic day. So you've been sitting in clinic, you're signing your 2000th Epic note, and your vision starts to get a little bit blurry, right? And it's getting blurry for 2 reasons. The first one is because you're concentrating on the computer screen, so your extraocular muscles are getting a little bit fatigued. And the second reason is because you're looking at the computer screen, you're starting not to blink as frequently as you should. So you develop a little bit of sicca. And that's the kind of visual loss that a lot of people complain about when you're asking them about giant cell arteritis, but that's not concerning for us, because that's the sort of visual problems that get better after the patient takes a break. The visual loss that we're talking about, or the visual symptoms we're talking about, really are things like amaurosis and field cuts, which I know you all know about. But I want to talk about some of the less common visual manifestations. The first one is blue vision. So when a patient first develops retinal ischemia from giant cell arteritis, there's a differential loss of rods and cones because the rods go first. And when that occurs, what happens is patients will notice there's a blue cast to things when they look at them, especially like white objects, so a white wall or a whiteboard. They're going to notice there's a little bit of a bluish tinge, and that can be the first sign that the patient has visual involvement from giant cell arteritis. The second one is double vision, and the tip-off for that clinically is going to be that you're going to notice that the patient is tracking you by moving their head rather than just looking out of the corner of their eyes when they're looking at you move around the room. And the reason why they're doing that is because subconsciously they realize when they look all the way to the left or all the way to the right, they're developing double vision. And the reason why that occurs to giant cell arteritis patients is because there's ischemia to the extraocular muscles. So when that patient's looking straight ahead, there's not a problem. But when that patient's looking all the way to the side, one of those muscles is going to lag behind. So they're going to develop disconjugate gaze, which gives them that double vision appearance. Now, if a patient complains about double vision, but they're looking straight at you, that's also not giant cell arteritis. More likely than not, that patient just has a cataract, so it's nothing we're going to have to worry about. Okay, so there are two questions you ask yourself. Is this new or is this recurrent disease? And the second question is does this patient have visual complications? And then I take that information and I put it into this particular approach. And this is traditionally the moment at which I stop so that you can pull out your camera phones and take a picture of the slide, even though you all consciously know that you've got a copy of your slides in the syllabus. So if any of you feel that impulse, feel free to let it go. But what I do with this information is I think if they've got new disease, they get treated with either weekly or every other week tocilizumab. If they've got recurrent disease, every week tocilizumab is better. For patients who have visual symptoms, I treat them with pulse steroid therapy up front. For patients without visual symptoms, they get somewhere between 40 to 60 milligrams of prednisone. So think 40 milligrams for Taylor Swift-sized patients and 60 milligrams for Travis Kelce-sized patients. And that's pretty much it. So I think the surprising thing on this slide, for some of you at least, is going to be the fact that I'm now recommending tocilizumab for pretty much all patients with giant cell arteritis. And it took me a while to get to that point because I've been treating giant cell arteritis for a while. And for many years, I treated these patients with glucocorticoid monotherapy. And I felt like I was doing a pretty good job for those patients, except apparently I wasn't. So the reason why I say that is because of the JACTA study, which, as you all know, is the study that led to FDA approval of tocilizumab for the treatment of giant cell arteritis. Now, this demonstrates the relapse rate in the patients who are enrolled in the trial. The top two lines represent the patients who are treated with tocilizumab. The bottom two lines represent the patients who are treated with glucocorticoids. And you can see from this graph how badly patients do if you treat them with glucocorticoid monotherapy, particularly the patients who are treated with steroids for only 6 months, because those patients have the highest rate of relapse. So I think this really drives home the fact that we can do so much better than steroid monotherapy for giant cell arteritis patients. Now, with regards to the frequency of tocilizumab, I make a differentiation between the new patients versus the recurrent patients. And the reason why I do that is because of this subgroup analysis from JACTA. So if you look at patients only had a brand new diagnosis of giant cell arteritis, again, we're looking at the top two lines. The top line represents the patients who are treated with weekly tocilizumab. The second line represents the patients who are treated with every other week tocilizumab, and you can't tell the difference. If you've got a new diagnosis of giant cell arteritis, every other week tocilizumab is just as good as weekly tocilizumab. So you can pick between the two of them. Now, for patients with recurrent disease, that's when it makes a difference. And you can see that in this graph, the patients who have relapsing disease do much better if they get weekly tocilizumab versus every other week tocilizumab. And that's when I think the dosing frequency really makes a difference. The recommendation for pulse steroid therapy for patients with ocular involvement giant cell arteritis comes from the Vasculitis Foundation American College of Rheumatology guidelines for the treatment of giant cell arteritis. And as one of the people who participated in the guidelines project, I can tell you this is not based on much. This is really based on not great data looking at the use of glucocorticoids for the treatment of giant cell arteritis, where they were able to demonstrate that pulse steroids probably really help with reducing the overall reliance on steroids and reduce the risk of relapse. But we've never been able to prove that pulse steroids actually improves the rate of ocular recovery. Now, the reason why I still recommend pulse steroids for patients with visual symptoms is because I hate having that conversation 2 or 3 months down the road, or a patient asks me, "Doc, is there anything else we could have done to help me get back my vision?" And because I hate having that conversation with patients, I will often pulse in those cases, just so we're not taking second guesses about whether or not we should have treated that patient more aggressively. On the other hand, though, if you've got a patient who you really want to give pulse steroids to, but you can't convince them to go to the ER because they've got those Taylor Swift concert tickets in their hand, I don't want you to worry, because there's data from southern Sweden that was presented to the ACR a couple of years ago that indicates that if you pulse patients with steroids versus give them oral steroids, you can't tell the difference. You can't tell the difference in terms of mortality, and you can't tell the difference in terms of visual outcomes. So the data that we're using to support the use of pulse steroids is really razor thin. Okay. You've got a patient with giant cell arteritis, you've got started them in treatment with steroids and tocilizumab, or maybe not tocilizumab. What do you do then? Well, for me, it really depends on whether or not I was able to get that patient started on tocilizumab. So let's talk about the tocilizumab-treated patients first. So for the patients who receive treatment with tocilizumab, I try to get them off of steroids over 3 to 4 months. I tried to continue tocilizumab for at least a year, and at that year endpoint, I basically asked myself, does this patient need to stay on tocilizumab? And the patients I keep on tocilizumab are patients with recurrent disease, patients with ocular symptoms for whom a second episode of giant cell arteritis could be devastating, and patient preference. Some patients would rather just not go through this again. They're tolerating tocilizumab just fine. There doesn't seem to be a reason to stop it. I'll let them stay on tocilizumab for longer. Now, when we get to the point where I feel like we're ready to start tapering the tocilizumab, I won't stop it immediately. I'll just start increasing the interval between tocilizumab injections till I get to once every 3 to 4 months, or 3 to 4 weeks, before I stop entirely. Let's say you've got a patient who you couldn't put on tocilizumab. That's generally going to be due to patient preference or expense or contraindications to tocilizumab. In those patients, I think they need to be on prednisone for at least a year. And that, again, goes back to the JACTA data that seems to demonstrate that the relapse rate in patients treated with prednisone monotherapy is much higher in the patients who are treated with 6 months of therapy versus 12 months of therapy. Past that point, though, I kind of ask myself a similar set of questions. If that patient has a history of recurrent disease, or if that patient has ocular symptoms, I'll tend to taper them just down to like maybe 5 milligrams a day of prednisone, rather than tapering them completely off. Now, this slide contains 3 statements that you guys might find a little bit controversial, so I wanted to go through some of the data supporting these recommendations. So with regards to the fast steroid taper, this is a study that was published by Massachusetts General Hospital around the time of the ACR meeting, where they looked at 30 patients who had a diagnosis of giant cell arteritis, 15 relapsing, who were treated with tocilizumab and a 2-month steroid taper. And they found that this regimen actually was remarkably good. These patients, sorry, the slide's moving without me. That's okay, we'll catch up. These patients were treated with tocilizumab for a year, and at the end of 52 weeks, 77% of these patients achieved a steroid-free remission with just 2 months of steroid therapy. Now, there were 4 adverse events, but the thing to remember here is that these patients may have developed these adverse events even if they weren't treated with tocilizumab. So I think overall, this is a remarkably effective therapy. The other reason why I think that this is an effective approach is because there is data supporting even shorter tapers of prednisone. So this comes from the GUSTO study that was presented a few years ago at the ACR and was updated at last year's EULAR conference. And the patients that enrolled in GUSTO had a new diagnosis of giant cell arteritis, and they were treated with a pulse of tocilizumab, 3 pulses of intravenous steroids, and then subcutaneous tocilizumab. And that's it. They didn't receive any more prednisone, prednisolone, no sorts of taper. They were just given that initial pulse of steroids and they were dropped off the cliff. And yet these patients also did really well. So of the 18 patients initially enrolled, 14 patients got into remission. Of the 13 patients who were in remission at 26 weeks, or 24 weeks, all of them remained in remission at 52 weeks. So taken in sum, I think these trials are telling us together that the real gift that tocilizumab is giving our giant cell arteritis patients is the ability to get off steroids that much faster. Now, I talked about gradually increasing the interval between tocilizumab injections in patients with giant cell arteritis. And the reason why I do that is because of this really bad data. Hopefully no one from Italy is listening to this conference right now, but this really bad data looking at the use of tocilizumab in patients with giant cell arteritis. So this is a study of only 17 patients who are treated with tocilizumab for giant cell arteritis for about a year. And after a year, all these patients were in remission. So far, so good. They then decided to increase the interval between tocilizumab injections from once a week to once every other week. And they found that these patients had a 12% relapse rate. They then stopped the tocilizumab entirely, and these patients had a 24% relapse rate. The good message here is that that means that 3/4 of patients did not relapse when you took them off of tocilizumab. The other important thing to remember here is that all the patients who had a relapse, they had minor relapses. They had like PMR, things that you would treat with a little bit of steroids. But it does indicate there's a dose response with tocilizumab in our GCA patients, and I'm hoping that by gradually decreasing the tocilizumab use, we can catch those patients before they completely fall. Now, the real answer to this question is going to come from the French. The French are conducting, as we speak, a trial called Magica that's going to look at different strategies for tapering tocilizumab in patients with giant cell arteritis. So hopefully we'll have real data for you pretty soon. Lastly, the last recommendation I want to talk about with giant cell arteritis is my tendency to leave patients on low-dose prednisone if they're not on tocilizumab, if I'm particularly concerned about them. And that's from this retrospective data that looked at a large population of patients with giant cell arteritis and found that even low doses of prednisone seemed to dramatically decrease the risk of relapse versus the patients who are tapered off of prednisone completely. So I think that maybe 5 milligrams a day of prednisone is not much of a price to pay in order to get that little bit of extra reassurance, especially in that patient who had visual loss but can't afford to be on tocilizumab for whatever reason. So now I want to move on and talk about eGPA, and for this, we're going to go through a second case. So this is a story of a 42-year-old man who 2 years ago started developing nasal congestion, decreased smell, and rhinorrhea. He then developed chest tightness, wheezing, and a cough, and the cough was so bad he actually fractured a couple of ribs. 1 year ago, he started developing nasal obstruction due to hyperplastic polyps. And his labs were remarkable for an elevated eosinophil count and ANCA positivity. So what's the next best step in this patient's management? First is an urgent nasal biopsy to make a diagnosis of eGPA. The second is intravenous methylprednisolone. The third is intravenous cyclophosphamide. And the fourth is subcutaneous mepolizumab. Okay, terrific. And again, there seems to be a little bit of a spread with the exception of cyclophosphamide, so that's great. No, this patient should not get Cytoxan. But let's talk about this. So traditionally, we think about eGPA as a triphasic illness, starting with asthma, and then moving into a hypereosinophilic phase, and then moving into a vasculitic phase. And I think this is a great mnemonic to remember all the components that are part of eGPA, but I don't think it's so useful when it comes to figuring out how to treat these patients. So in order to treat patients, I'm going to suggest that you use a slightly different model. Peanut butter and jelly. I think that patients with eGPA really behave like peanut butter and jelly. They're basically two separate things that just happen to show up at the same time. So the jelly in this case is the respiratory tract manifestations, and the peanut butter is the systemic manifestations. The respiratory tract manifestations really divide into upper respiratory tract and lower respiratory tract manifestations. The lower respiratory tract manifestations are just asthma, they're bronchospasm. The upper respiratory tract manifestations predominantly are going to be chronic sinusitis and nasal polyposis. For the systemic manifestations, you're thinking about manifestations driven either by eosinophilia or by vasculitis. For the eosinophilic manifestations, these patients develop symptoms depending on where those eosinophils show up. So the eosinophils in the heart cause myocarditis. The eosinophils in the lungs cause fleeting pulmonary infiltrates. The eosinophils in the gut cause eosinophilic colitis or eosinophilic esophagitis. And the eosinophils in the skin cause urticaria. And for the vasculitic manifestations, these are the ones that we all now know about. It's going to be monorized multiplex, pulmonary hemorrhage, and glomerulonephritis. So with regards to initial management, these patients should all be on inhalers up front. And the reason why I specified 3 inhalers by name is because these are the cheapest ones. These are the ones that the patients can get for about $80 a month. It is criminal how expensive inhalers are in the United States, but this is the best that you can get price-wise. I typically will start patients with both inhaled and intranasal glucocorticoids when they're on prednisone 40 milligrams a day. Not because they need it at that point, but to get them into a routine. So they've gotten used to using these inhalers twice a day. So as I taper the prednisone, these steroids are starting to take effect. For patients who are continuing to have symptoms despite the use of inhaled glucocorticoids, I move to interleukin-5 blockade. I don't fool around with IgE blockade. I don't fool around with leukotriene inhibitors. I go straight to interleukin-5. For these, remember that there are 3 interleukin-5 blockers that you can use. Both mepolizumab and benralizumab have been demonstrated in clinical trials to be effective for EGPA. The reason why you need to know about reslizumab is because insurance companies are evil. And some insurance companies will not pay for a subcutaneous biologic, but they will pay for an intravenous biologic. And reslizumab is the one intravenous formulation of an interleukin-5 blocker that you might be able to get your patient. So the reason why we use mepolizumab for the treatment of EGPA is because of the MIRA trial. And I just wanted to go through this Kaplan-Meier curve to remind you about the pharmacokinetics. So if you look at this graph, you can see it takes about 2 months for the patient to start to have a clinical response to mepolizumab. So if they don't have a response to that first injection, tell them not to give up. The second point is that it takes about 6 months to get a maximal response. So it takes a while before the patient knows the extent of the benefit they're going to get. The third point is that there's only a short honeymoon. So after the patient stops treatment with mepolizumab, after a couple of months, the effects are completely worn off, and they're back to being the patient they used to be. Benralizumab was recently presented at the ACR meeting as also being effective for the treatment of EGPA in a head-to-head study that looked at benralizumab versus mepolizumab. And you can see from this Kaplan-Meier curve that the effects are identical. The thing to remember here is in this clinical trial, they used benralizumab once a month, whereas the dose that's currently approved for asthma is benralizumab once every other month. Whether the more frequent dosing is important for the treatment of EGPA patients, I don't know yet, but I think we're about to find out. Let's say you've got a patient who you've done all that for, and they're still having upper respiratory tract symptoms. What do you do then? Well, for a lot of patients who've got chronic rhinosinusitis, I'll give them intranasal ipratropium or intranasal Atrovent. And the reason why is because a lot of these patients, they're going to have symptoms that are driven by the fact that they've got postnasal drip. And for those patients, giving them a little bit of intranasal Atrovent will dry up the nasal secretions and will improve their symptoms quite a bit. The other thing I've noticed is a lot of my patients pick up seasonal allergies, even if they didn't have a history of seasonal allergies before their EGPA diagnosis. So a lot of these patients will benefit from being on antihistamines for maybe 3 or 4 months out of the year. For a patient who has refractory asthma despite maximal interleukin-5 blockade, I don't know if there's a straightforward answer. I've been starting patients with tezepelumab, which is being looked at in clinical trials currently. So far, it does seem to be effective for the handful of patients I've used it in, but that's not a real answer yet, but a real answer is forthcoming in the near future. For patients who have chronic nasal polyposis, the first thing I'm going to recommend are better delivery systems for steroids. There are better inhalers. There are also nasal steroid implants that you can give patients that might be more effective than the Nasonex that they get over the counter. These are not drugs that we can prescribe ourselves because insurance companies will hold back funding for these particular interventions like the dragon holding on to its gold. These are not cheap interventions. But the reason why I list them here is so that you can reassure the ENT that's working with your patient that these can be very effective for EGPA. For patients for whom these are not options, dupilumab is actually a great treatment for nasal polyposis, but I'll give you two caveats. The first one is you can't use it in patients who have very high eosinophil counts. So if you have a patient with an eosinophil count of like 1,000 or 2,000, you probably have to avoid dupilumab. The second caveat I'm going to give you is you have to be ginger about the prednisone taper, especially during the first few months of therapy. And the reason why I say this is because of these data that were presented at last year's ACR meeting looking at dupilumab for the treatment of patients with refractory EGPA symptoms. And the good news is that it seems to work, that 66% of patients had a clinical response. The bad news is an equal number of patients develop hypereosinophilia. Not a bad thing by itself, but in about half of those patients, they did have a relapse involving one of these organ systems. I think this is going to turn out to be the leukotriene story. I think what happened to these patients is that when they started on dupilumab, the patients were doing so well, they just got tapered off the steroids too fast. And that's the reason why they had an opportunity to flare. And that maybe we just have to be a little bit slower with prednisone tapering and these patients will do okay. The hypereosinophilia that occurs in these patients is transient. It tends to wear off in 3 to 4 months. So that's really the time that you have to be careful with patients. I think longer term, this could be a stable regimen for at least some patients with EGPA. Now, for patients who have non-respiratory tract manifestations, you have to think about the etiology. For patients with eosinophilic myocarditis, cyclophosphamide is still the treatment of choice. For patients who can't use cyclophosphamide, I use interleukin-5 blockade, which is also what I use for other eosinophilic manifestations. For patients with vasculitic manifestations, I also recommend cyclophosphamide because that's where the data are. But if I can't use cyclophosphamide, I don't hesitate to use rituximab, which seems to be effective in these patients. For patients who have got milder vasculitic manifestations, I will tend to use an oral agent like methotrexate or mycophenolate mofetil. I tend to shy away from azathioprine because of a clinical trial called CHOOSE-SPAN-2 that seemed to demonstrate that azathioprine for mild and moderate EGPA was not effective. This was a French study. Americans don't believe the study, so we still tend to use azathioprine in these patient populations, but I will say it's fallen a little bit lower on my list, particularly because of this trial. So this is a summary of everything I just said today, so you can take another photograph of that, and thank you very much for your time.